it's important to recognize how industry can influence us in good ways and sometimes in potentially not good ways.
Welcome to EyeCan, a podcast about ophthalmology through a uniquely Canadian lens with Hadi Saheb and myself, Heather O'Donnell. Season 5 of the EyeCan podcast is brought to you by Bayer Ophthalmology. We thank them for their support.
La saison 5 du balado EyeCan vous est offerte par Bayer. Nous les remercions pour leur soutien. We will be sharing our experiences as ophthalmologists today and tackle some of the challenges we face as healthcare providers.
Dr. Chryssa McAlister is Co-Division Head of Ophthalmology at Waterloo Regional Eye Program, Staff Ophthalmologist at St. Mary's General Hospital and Grand River Hospital, and Assistant Clinical Professor Adjunct, Waterloo Regional Campus, McMaster University. Dr. McAlister runs a diverse, comprehensive medical and surgical ophthalmology practice and manages a wide range of ocular conditions. She performs cataract and strabismus surgery, intravitreal injections, and various laser procedures. She also sees pediatric patients with eye disease in the Waterloo region.
What an impressive, comprehensive practice. Dr. McAlister helps to coordinate the WRC medical student teaching in ophthalmology and delivers the ophthalmology review session for graduating medical students at McMaster University. Dr. McAlister is involved in the bioethics teaching for postgraduate ophthalmology training programs at McMaster and the University of Toronto. She helped to organize the Halifax Ethics Symposium and in 2023 founded the Macrae Bioethics Professionalism course in ophthalmology, a biannual national review course in ophthalmology bioethics. She's frequently invited to speak at conferences on topics of bioethics in ophthalmology and medical education. Dr. McAlister is a director of community practice on the board of directors of the Canadian Ophthalmological Society. Today, we're discussing some of the ethical challenges we face as ophthalmologists, from the role of private for-profit facilities to the influence of the medical industry and the integration of insured and non-insured services. Ophthalmologists face unique ethical challenges. So in this episode, we'll dig into how these elements affect both practitioners and patients, raising important questions about transparency, fairness, and patient care. Chryssa, we're so happy to have you. Welcome to EyeCan.
Thank you, Hadi. Thank you, Heather.
Before we get started, I want to say two things. The first one is, I'm a bit starstruck by this guest. So ever since I have met or known about Chryssa McAlister and people started talking about her, there was a conference a couple of years ago where I was looking for somebody to come and speak on ethics and she was recommended. And when you came, you delivered this amazing lecture to the audience that made every single person in the room want to be a better doctor. And I was so grateful for that education seminar. And I was so grateful for every time I've gotten to see you speak since then. So I'm always wowed. And I'm also so excited to potentially be kind of put in my place and reminded, watch yourself. There's probably some changes you could make to your practice right now if things have slid in a direction that you might not be aware of. So thanks for coming and thanks for keeping us in check.
Well, thank you, Heather. I'm blushing here, but thank you.
No. Okay, so the first thing we're going to tackle, the broad area, is really around how our profession is potentially even uniquely impacted by our engagement with industry and pharmaceutical companies. So the first sort of question that I think we should pose to you, I'm going to ground it in a bit of a story, which is, I have this busy, comprehensive ophthalmic practice. I'm seeing lots of patients in a day. And during that day, occasionally reps will arrive at the office and they will drop off samples of whether it's artificial tears or glaucoma drops, and they go in a drawer. And I try to ethically place them in a place that my patients don't see them. And for the first couple years of my practice, when I'd hand out drops for dry eyes, I'd say to patients, I don't work for this company. You can buy whatever you want, but here's a sample to get you started on your dry eye routine. And recently, just in the past year or so, I've stopped saying that because I realize every time I'm handing out this box of tears, indeed, I am working for the company, whether they're directly paying me or not. So can you talk to us a bit about where do you see industry positioned in our practices right now? Are you comfortable with what's happening? And where do you see this, if there's a problem, what is it?
I think, Heather, it's not actually that unique. Like, I think in medicine, in most specialties, there's some industry. Now, some are different. Like my sister's a general surgeon. They don't have many industry reps trying to encourage them to use products. But my husband's an orthopedic surgeon. They have tons of devices with their joints. Definitely in family medicine, they have the pharmaceutical side. I think it's a very well understood concern in medicine, the influence of industry. So it's not unique to ophthalmology, but what is unique is we have like the double prong. We have pharmacology rather, so with our drops. And then we also have devices with our implants, and there's glaucoma devices. There are many kind of different devices that we look at. We also have lasers. We have many different industry roles. And before we get into the ethical controversy, I think it's important to identify how important they are. Like we really do rely on industry relationships for research, for education, for a lot of our CME, a lot of the COS content at courses. There will be some sponsorship with industry. So I think sometimes when we talk about the ethical concerns of conflicts of interest, which is one of them, industry relationships, it sometimes sounds like we're anti-industry, which is definitely not true. But that doesn't still negate the fact that there are concerns with having industry relationships as physicians. And there's so many of them, like what you mentioned, which is samples in the office. Mm-hmm. That's a longstanding one. And if you look at the literature on industry influence, it's one that's often brought up as a real easy one for industry, because we know there's this concept called reciprocity, where as social humans, if someone gives us something, we have a very strong tendency to want to do something nice for them. So there's one component that samples are one aspect of gift giving, which there's others, there's, you may have heard of an organization called No Free Lunch, which is this idea that when industry representatives buy your staff lunch, buy you lunch, buy the nursing team lunch, pay for the dinner for the CME course, that, there is this relationship that you develop with them. And the main concern is that will influence what you do. And we know that it does influence what we do. There's clear evidence-based literature that shows that physicians in ophthalmology, but also in all other specialties where there's industry, are influenced by the relationships we have with industry, and also that we're terrible at recognizing it. So we all think that we as individuals are immune from influence, but that our colleagues are not.
We're particularly special in so many ways. We like to think we're very special. Yes. Somehow we're immune to this bias.
And one little thing that relates to this specifically with prescribing of drops is that industry can actually track how successful they are. So they drop off, the newest glaucoma drop, and then they can essentially buy your prescription records and very clearly see before and after, was the influence successful? Did you start prescribing that drop after the samples were given, or after the dinner was paid for, or after the educational event happened? So I do think we need to know as ophthalmologists, first, that industry influence is very well understood. It happens, and they know what they're doing. Like their goals are different than ours. Their goals are to their company to sell a product that often is of benefit to our patients, but that they may be trying to influence us in ways that we don't know that we're being influenced. And I would say there's a concerning naivete in ophthalmology regarding how that influence actually impacts us.
Can I ask you about learners and how this impacts the most junior of us in our profession? Do you think it's a more concerning impact? I know that learners, at least at my institution, there's a very clear policy about learners not interacting with industry, but I'm not sure that this is entirely, sometimes I feel like it's not realistic, in that I know as soon as they graduate, they need to interact with industry. And there's this idea of, are they being adequately debriefed about what this relationship really is? Are we teaching them enough?
I think there's 2 points. You are right. I think that the earlier you interact with industry, the more normalized it is. Gordon Guyatt, who's a very famous physician in Hamilton, did a study quite a while ago looking at residents, not in ophthalmology, but in medicine, but found that the earlier that industry was involved in training programs, the less likely the physician was to identify it as a concern. So if you were, as a medical student, if you had industry around, then if you were asked later on, are you concerned about conflicts of interest, you would be less concerned. Whereas if you wait until you're more mature as a physician in your training, that you perhaps identify those red flags a little bit better. But I do think you raise the other issue that we may not. The first is the exposure, but the second is the training surrounding industry influence. And I mean, there's a ton of literature there. It's not new. It's actually decades old, the literature showing the impact of industry influence and the psychology of being a physician and how that can impact your patient decisions. So I do think we could do a better job.
Formalizing it in our educational curriculums, perhaps, or ensuring.
Or prioritizing it. I mean, I would say the part that bothers me the most is at meetings. I would say we have a lot of industry presence at meetings and speakers that are clearly heavily involved with industry, often wonderful speakers, but that the disclosures that we see at meetings, and this is at all meetings, American and Canadian, local and national, I would say they tend to undervalue the relevance of disclosures, sometimes laugh about disclosures. Oh, how could I be conflicted? I have so many conflicts of interest. And I think that really does a disservice to the concept that it's important to recognize how industry can influence us in good ways and sometimes in potentially not good ways.
Chryssa, there's so much you said there and so much to unpack. I'm wondering if somebody came to see you, feeling very connected to the principles you're sharing and asking you, Chryssa, I'm going out in practice right now. I have a vision to make an impact on the field, do research, teach, be at conferences, be an educator for my peers. What are your recommendations for me to navigate these conflicts, and what would your advice be on how involved or uninvolved to be and how to declare these things? Like, what are your general recommendations for people that are quote unquote wanting to do it right?
I think there's so many things you can do, Hattie, and I think there's no kind of clear course for any one person. Many of our stars in ophthalmology are very involved in innovation and research that's directly with industry. And I would say if that's your path, to recognize that industry influences every level of research and care. So be really cautious about how you design the methodology of your research papers. I would make sure that you look into what's the history of industry influence. There's a lot of examples in other fields where industry influence has really negatively impacted the design of papers that was not identified early enough, published in like New England Journal, big, very reputable journals, afterwards retracted because it was recognized that the design or the methodology was not great. There's so many areas where if you had good knowledge of the history, it could really positively impact how you move forwards with it. I definitely think industry relationships are important, but I think you have to be smart about it. So I would say the basic one is that most of us don't know anything about the history of industry influence in research, but also in clinical practice. There's a lot in the literature there. So I think becoming more familiar with that, and also recognizing that you are not immune. So if your intuition is to think, oh, well, I'm not conflicted, kind of like what Heather said, where you're like, oh, I don't work for this company, but recognizing that that's maybe not necessarily enough, so that you sort of take a minute to reflect, maybe in a kind of mindful way. I do that. I do private cataract surgery, which, is a version of this where, you feel like you may have influences in your decision surrounding patient care. And I really make a point of thinking, what would I recommend if this was my mother? Or what would I recommend if this was, someone that you really care about? You want to make sure that the decisions you're making are the right decisions for that patient. And that also that there's an unconscious bias, so that even if you're doing all of that, you may be influenced, so that you need to make sure that when you are reviewing the literature, you're reviewing good literature. So for example, me in practice as a community ophthalmologist, I do so many different things. I'm not going to read all the original papers. I often go to the review articles. And it's really well known that, especially in kind of lower impact journals, review articles are a fantastic way to deliver a biased message. If you look at the femtosecond literature, it's fascinating, especially when it first came out. There are tons of review articles saying how this is, this technology has improve clinical outcomes, clear superiority over phaco without femtosecond laser. And then you'll have review articles in more reputable, higher impact journals that are more systematic who say, there are these technical outcomes that look more positive, but clinically there's no difference. And it's a completely different outcome and recommendation looking at supposedly the same literature. So I guess being a little bit less naive and a little more educated probably would help you in all aspects.
So if I've shrunk my blind spot a bit, and then, so that sort of seems like it's our first step, like make sure you're aware, you know that you have it, and if you can shrink it, do it. But if there's always going to be this underlying bias, what do you think of our role in disclosure of it? How do we maintain transparency? If it's not a list coming just behind our introductory slide at our conference, if it's not that, what does it look like that you would feel comfortable that you've disclosed that you may have that bias? Is it a conversation with every patient? Is it something on your practice website that says, here are the disclosures that I am presently aware of, and there may be others because I do interact with industry?
I think there's some good guidance for that, Heather, that you can look to if you're specifically looking for a situation. At conferences, I've always felt like we need a thing called meaningful disclosures. So you can list everything. But if I'm going to talk about anti-VEGF injections and I consult for the anti-VEGF companies, I think I would take an extra second and explain that and how that is a meaningful disclosure for this conversation. And so that does happen sometimes. But I do think as a listener, if that disclosure was made, I would maybe hear the content slightly differently than if I didn't know. So I think spending a moment acknowledging that conflicts can exist. You can also acknowledge how you resolve the conflict. So say it's a very clear one, like I'm going to talk to you about a product and I developed the product. So I receive royalties if you use this product. I think what you could say is first you have to disclose that, acknowledge that it is an important disclosure, not make a joke about it, but then also say, this is how I design my presentation to work around it. So I'm going to present to you some other products that I think are equally useful in these other ways, explain why I designed my product, but, show the audience that you're making an effort to show an unbiased presentation, even if you know that you have these influences. I think it's a lot different with patients. I've thought about it a lot because when you speak with patients, we have way too much to talk to them about. If I talk to them about, like, say, just take cataract surgery, you talk about the surgery, the risks, you talk about the non-insured services, the cost, you talk about the trainee, the role of the trainee. And then I'm going to say, oh, and I consult for Alcon and Bausch & Lomb and Johnson & Johnson, but but it's not going to influence this lens because this lens is this other lens. I think you've lost your patient completely.
Yes.
So I think you have to take it patient by patient. And I will say, for example, when I talk about implants, and I use all the different companies available to us generally, but I have certain preferences. So I'll say, for this multifocal implant, this is the implant that I'm currently using. I do not work for the company. I mean, I tell them that, I don't have a relationship with this company. And for me, I actually have made a point of not having industry relationships where I get paid by industry, recognizing that doesn't mean I'm not influenced, but it has been an important thing for me to maintain, but I don't think that's appropriate for all ophthalmologists, but you have to figure out kind of where you fit in that.
I think that's a lot of great material for chewing on and thinking about. And I think that's one of your key messages here is we need to take some time to actually reflect on your practice pattern. But
it actually makes you happier too. If I could just add that,
yeah.
I derive a lot of joy from my practice, as I think all of us do, particularly when we have such, satisfied patients with their outcomes. But, taking that extra time to kind of think, how can I do this in the way that I think is best in terms of the most appropriate for patients, the most selfless in a way in terms of a physician, the most patient-oriented. I do think at the end of the day, you derive a lot of satisfaction from that.
Let me ask you about, you're talking about, when you're talking about disclosures, you're sort of speaking about it from the perspective of what one should do when they are the speaker. Can you tell me about when you specifically, Dr. Chryssa McAlister, ethics expert in this realm, are sitting in the audience? How do you see your role, obviously by being here and you have all these amazing initiatives where you're advancing the knowledge and information, but when you're just sitting in there, you would start to hear influence that you're not satisfied with. How do you balance sort of accepting that this is the state of affairs versus putting up your hand and saying, I'm not okay with the way that we're disclosing this here? And how do we empower people to be the noisy folks in the audience? Maybe as the three of us here, we're a bit seasoned. We've been around for a while. Is it time for us to start standing up and saying, hey, before you continue, I'm not okay with how we're proceeding here. Can you lean into that conflict a little bit more? Would you like to see more of that, or do you think it's unrealistic?
I would love to see more of it. I have to say, I sometimes wish I could do that. I don't know how effective it is always, because I think sometimes when you speak out in that way, especially with something that's perceived to be ethicsy, which often sounds a little bit pious, people first, like everyone has this natural tendency to make it black and white. Like I've been involved in debates regarding some concepts regarding innovation. And if I have found that if I make any criticisms regarding industry influence, there is this general statement that I must be anti-industry or anti-innovation. And it's so clear to me that those things don't mean the same thing. But I do think there's a tendency for that, so that it sometimes makes it hard to have a meaningful conversation in that kind of public setting.
Yeah.
But I am inspired by that. When I was a resident, I saw Brenda Galley speak out at a meeting about a new treatment for retinoblastoma that she felt was not well studied. And I have never been so impressed with someone able to speak out at a conference in front of who was supposedly, the expert in this area, saying, what you're saying is not appropriate. And I wish we could have more meaningful discussion in general in ophthalmology like that. But I don't know really if that setting is the most appropriate, because it becomes maybe a little bit too emotional for people. I do think small group settings are better settings. Like when we have had our Halifax Ethics Symposium, and then more recently now the Macrae course for residents, those tend to be groups of 10 residents. But I think it would work for physicians as well, like not physicians, but like fully trained ophthalmologists, where you have meaningful conversations surrounding these things. I mean, sometimes when you see a presentation that is blatantly industry biased, I'll say, which I have seen many of, I would like to speak out, but I often don't see it as being that helpful.
Thank you so much for that. I think we're gonna move on and open a whole other sort of can of worms.
Before we do, I think, people like you, Heather, Chryssa, so many other leaders and future leaders are involved in meetings. And I think, whether as a speaker or as a, part of the organizing committee, Chryssa, you're on the board of directors of the COS. I think there are so many opportunities to share, what we're discussing today. I'll give an example, and I know I can do so much better, not only as a meeting organizer, but as a speaker to be more mindful about this. But for example, in a meeting I'm planning, we're considering for the next version to mandate that the speaker count till 5 on their disclosure slide and just sit there and count till 5 for every single talk. And I think a potential next step would be to have not only one slide, but then a second slide. We could call it a meaningful disclosure, right? And I think there's a way to do this, if we can rally enough people to understand why we're doing this. And Chryssa, I think as I listen to you, have this really unique ability to speak about this in a way that feels good, that feels right, that doesn't feel too pious. I don't know what your magic is.
Good.
But
Thank you. I worry about that part.
Of course, it's so tough to talk about this in a way that can resonate with the majority of our colleagues, which is ultimately what you want, Chryssa. I can tell that what you want is to impact the field in a way, that's good for us, for our patients, for perception, and so many good things. And so I think, people like you and people, like us that are involved, and people like our listeners that are involved in meetings. I think you can suggest these things, do it in the incredibly respectful way that Chryssa is doing it, which is so impressive, but I think it's worth it. And I really, it really resonates with what you're saying, really resonates with me.
EyeCan wants to know what you think. Please send your comments on today's episode or any suggestions you may have for topics or features to communications@cos-sco.ca. and we'll try to incorporate them into future episodes.
EyeCan veut savoir ce que vous en pensez. Veuillez envoyer vos commentaires sur le balado d'aujourd'hui ou vos recommandations de sujets à communication@cos-sco.ca et nous essaierons de les intégrer dans les prochains épisodes.
Je suis Mona Daguerre et j'écoute le balado EyeCan.
We kind of touched on this, so we'll make a little bit of a segue into one of the trends we're seeing nationally, which is the private surgical facilities for cataract surgery. So, Chryssa, I'm curious to know what you feel are the ethical implications of cataract surgeries and other procedures moving into private for-profit facilities.
Well, I have a lot of experience with this because in Waterloo, we've had a relationship with our local private center since COVID. And I think generally when this is discussed publicly, it's confused a lot because there are many different relationships that can happen. Like when COVID happened and we had a shortage of nursing staff were redeployed, we just couldn't do cataract surgery in the hospital. So our hospital formed a relationship with the private center, got permission by the ministry where they could essentially funnel cataract surgeries to the private center. But the hospital essentially still controlled the volume, still controlled the funding. The hospital received the facility fee and just paid the private center to do the procedure. So they essentially kind of just like rented the space. The patient still had the discussion for cataract surgery, the referral for cataract surgery, and the question of non-insured services done in the same way as they would have through the hospital. So in many ways, that was a perfect option because we could do appropriate patients through this private center, patients who are more medically complex. We could still do at the hospital, but we had an ability to do more volumes. And that relationship that we have continues today and has been only positive. I would say that the surgeons love working through the private center. The efficiencies are great. We have access to all the disposables we want. Really, there is no difference in the care model at all, except that we don't do, at least in ours, but this is very different in different centers. In ours, we don't do IV access. But I know in Calgary, all the private centers do IV access. So that's not a private center thing. I think that just depends on the private center. But really, the model that I think is more concerning and could have potential risks is this model where the government, I think it was now a year and a half ago, awarded contracts to a private center bypassing the hospital. And in Ontario, that's a new thing. In Alberta, that's been, I think, around for a while. And I'm not sure how it stands in the other provinces. But essentially, that means that now this private center does cataract surgery directly without involving the hospital. And it's not always clear who's going to do those cases. What kind of responsibility will that surgeon have to the hospital, to doing call, to the community? And in a community of my size, which is, 600,000 patients, something like that, there's only 8 ophthalmologists in Kitchener, 16 in our region. It actually makes a huge difference if there is this option for doing cataract surgery outside of the hospital setting. And this issue was raised by many of our leaders in ophthalmology on a very national platform with the Toronto Star and the Globe and Mail. There were editorials written at the time saying, we need to make sure ophthalmologists doing surgery are taking call at the hospital. They have access to the services at the hospital. Like if your patient has an eye infection, they may need intravitreal injections. You need a pharmacy for that. There's many things that we need that are hospital-based that we need to be linked into. Now, our community now has an IHF as well. But because we had this pre-existing AHF is the one of, so the alternate health facility is the name of having a relationship through the hospital. Because we had that already, our private center said, well, let's just do the IHF cases the same way. So that actually made it very good for us. So really, there's no difference in our community between the IHF that bypasses the hospital and the AHF that does not. But it's not mandated that way. So I think there's a lot of concerns raised in communities where there's not rules surrounding that, who's going to do those cases. And there's actually a great paper that came out, you may have seen it in the CMAJ in August by Rob Campbell and their group, looking at access. And what they wanted to know is, looking across Ontario, when private centers were given more cases to do cataract surgery, was there a difference in who got to access those cases from a patient perspective? And what they found was that patients who had a higher socioeconomic status got better access, but patients who had a lower socioeconomic status, their access actually worsened despite the volumes increasing. And it's hard to know exactly what that means because they didn't really identify, like, I'm not clear if I look at my community, how that would play out in my community. I don't think it would, but it makes you worried that, if a private center that's for profit has direct cases, there is a risk that patients maybe are only referred there if they're willing to pay for private services, that if they're not willing to pay for those services, they may not be able to access cataract surgery or those volumes. And then generally there could be an access problem for our more vulnerable, lower socioeconomic status patients. So there's kind of multiple concerns, one about patient access, and then the second one about serving our community for non-cataract needs, like call through the hospital, medical eye disease. I would say if you look at most communities, there is a long wait sometimes for cataract surgery, but there's often a more concerning wait for advanced medical eye disease. And, it could make that part worse. And a lot of those conditions are blinding in a permanent way. So I do worry about not having strict rules surrounding it.
For our listeners, can you just define again? I think you said AHF, alternate health facility, and IHF?
IHF is an independent health facility.
Thank you.
Now, it's kind of confusing because IHF is also used for radiology centers. They have IHF licenses. But in this context, an IHF is essentially like a center that can do surgeries outside of a hospital. And before, in Ontario, any of the IHFs that existed either predated Medicare, so they were from before 1968, or it was Kensington. And then just in the last year and a half, there were 3, Windsor, Ottawa, and Waterloo, who were given direct licenses. Now, since then, it may have increased to other centers. I'm not totally clear on how it's changed. But as far as I know, those are the 3. So it was actually for Ontario, that was a big change where you no longer had surgical volumes kind of controlled by a hospital budget.
So Chryssa, we've talked about insured and non-insured services, and both these categories can be considered both in hospital centers and non-hospital clinics. What is your take on the ethical challenges that arise from, having this category of insured and non-insured services for patients?
There's sort of several issues that come up. The most basic one that we all face is our patients' ability to understand and navigate healthcare when you have an insured and an uninsured service offered simultaneously. My understanding, other than blepharoplasty, where you can have like a ptosis repair and a bleph at the same time, there really are very few surgeries in healthcare that you have simultaneous insured and non-insured services. Like if you have a joint done, you can't pay for the joint, at least by our current rules. So it means that most of our patients are not really prepared to have that conversation. So I think many patients come to us not really knowing there are options of non-insured services. And in Canada, where we expect everything to be covered, sometimes it's an uncomfortable discussion, both for the patient and for the surgeon. So there's many different approaches. I've seen people kind of just not talk about it because they think, well, let's just not talk about the non-insured services. And I would say when I started my practice, that was more common about 12 years ago, although I would say at that time, it probably was not acceptable. Now I would say it could be completely unacceptable because I would say many of these services have significant value, and it is really a patient's opportunity to reduce or eliminate glasses. And I think many patients would be quite upset to not be given the option. Patients in Canada value very much autonomy. They want to have the right to make their own choices, and they want the information they need. And I don't think you could argue that this is not information they need. So you have to kind of figure out a way to make it meaningful to them. But then there's so many other nuances to it. How are those services offered? Do you delegate it to someone else? I can see why you'd want to. I find it an exhaustive conversation. I had a day of cataract consults today, and it's almost like voice abuse by the end of the day. You're saying the same thing over and over again. And I do think after time, I sometimes shorten the conversation. I get a little tired. And if I get the sense, you know what, I'm like, the first thing I say is, so what do you do with your glasses? Do you wear them all the time? And if they say, oh yeah, I wear progressives, I don't ever take them off, I love them. And then they're like, say they're like a mild hyperope, they're going to be so happy. I sometimes may say, well, are you okay with readers? And they say, yeah, I'm fine with readers. Okay, great. Let's just go ahead. Monofocal, let's go.
I remember, correct me if I'm wrong, I remember the very first lecture that I ever heard you give. Chryssa, you said, I'm going to take issue with the word premium. Can you tell, is that still a word that there's practices across the country that tell their patients there is a standard lens that the government pays for as part of your health plan, but then there are these quote
upgrades,
premium options or upgraded lenses or
I hate it, Heather. And I think because I hear it differently now that I've thought about it.
I mean, it seems, frankly, when I say it, of course,
it sounds like you're selling a car, kind of.
Right. Are you a patient or are you a customer? How do we make it very clear to them that this is not about, becoming a customer and choosing something from a menu list that just happens to be, if you can afford it, pick the most expensive. Obviously, that's going to be best for your eye.
Yeah, which often is not.
Of course.
Well, I think first it is important to recognize, why do we use those terms?
Yes.
And so number one, you could use them because you want patients to pick those options. You get paid more if they pick a non-insured service. I do think that is one rationale. But I think probably for most people, it's actually either just the language you were taught, or it's just like an easier way to explain it, because it's so technical. It's kind of hard to kind of go through all the differences. So I think we default to those terms to simplify the conversation, which makes sense. It's an annoyingly complicated conversation for patients. But I do think recognizing that those are value-laden terms, and patients for sure will have a certain biases where they'll think, if it costs more, it must be better. We know patients love lasers. Are you going to do that strabismus surgery with a laser? Like, they really want it. I wish I could say yes. Like my dog had to have a surgery and they asked if I wanted the laser incision. And, you can tell that it really plays to our vulnerabilities. Patients think lasers are precise, more accurate. So when we're offering these options, we have to first recognize patients have these vulnerabilities and biases that we have to address. So for example, femtosecond laser, I do offer femtosecond laser as part of cataract surgery. I will recommend it in a patient who's having a refractive lens exchange with a multifocal, where they don't have a cataract. It's a purely refractive procedure. And I say, look, you just want it perfect, and I think especially if it's a multifocal, but I say, there's no literature that shows that it's clinically better, but there are some technical parameters that are perhaps better. And in this scenario, this makes sense to me. But if I have a patient who's having a monofocal, I tell them, I wouldn't recommend it to my mother. My colleague just had his surgery. He's a surgeon. He didn't get it. So I try to make it clear to patients what has true value and it doesn't have value. And I think probably the easiest way to think about it is to take out the cost completely. So somehow, because patients pay for it and because we get paid for it in a different way, maybe than other insured services, I think we have the conversation differently. But if you just pretend like you're not getting paid and they don't have to pay, what would you recommend to them? And I would try and have the conversation that way. But then if the payment is an issue, like I had a patient today, and many patients will say this to us, where they'll say, what is it going to cost? I want the best option. This patient was asking because she put it on her Visa card because she couldn't pay for it out of pocket. And recognizing it's in our code of ethics that you have to consider a patient's ability to pay when we offer services, and that the amount that you're recommending needs to be a reasonable amount. So these non-insured services, sometimes the amounts vary quite significantly. So I think knowing that what you're offering is considered reasonable is important. But, really thinking about, is this of value to that patient? So if it's a patient where it's not going to really affect their outcome clinically, I think I would tell them that. I would say, for you, it probably isn't going to make a big difference. But if it's a patient with high astigmatism where, it actually would really impact their outcome, or a patient who hates glasses, who would love to be glasses independent completely. You just take the extra time. So I guess the main thing I try to do is I try to take the money out of the equation to begin with and think about what is the best for this patient if everything was free, or if I didn't get paid differently no matter what they picked. But then consider the money from their perspective. And if it's going to break the bank and it doesn't make a difference to them, I would make sure they know that.
Obviously, all of this takes time, Chryssa. So, it's tough. There's, as you said before, the cataract consultation is already pretty heavy for the patient and for the surgeon. And then you add these nuances, and how are you going to tell if it's, what is their ability to pay, and how do you approach that? Do you ask them directly? Do you look at, the way they're presenting themselves? There's so many nuances. It's so tough, but I think what you're sharing are the principles that we need to have and to keep in mind. And obviously, there's no one way to address all of these things. I wanted to touch on something regarding balancing, the profitability of our practices with, this commitment and this upbringing and medical training of patient-centered care. So I'm in glaucoma. It's a huge burden of care. So, most days at the end of the day where I've seen so many patients, I feel like I'm, serving my community by taking care of patients efficiently. And, doing a lot of visits, a lot of procedures. I feel like, in the glaucoma space, this is something important and needed by our community. But there's no question, this is we are in a fee-for-service profession where volume also is compensated generously. And so, most days I feel great about it because it's really about patient care. But there's no question that this is not something that's openly talked about. We're not talking to our trainees about, what it means to see X number of patients versus a lower volume. How are you thinking about this? The need and or the desire to be profitable in your practice in the context of something that's fee for service, but also this upbringing and this overwhelming pressure to always keep it patient-centered. How does this sit with you?
I mean, I think there's a lot of ways you can look at it, Hattie. So I have a solo practice. I own all my equipment. I have all the lasers in my office. I have an indirect for doing retinal tears because it saves me time. And at my stage in my career, high overhead is worth it for time. Like my time is so valuable. I've got little kids. And I think that's true for a lot of us. So I do think we tend to have high overhead practices. I also value efficiency, and I like to be, I'm efficient at everything in my life, actually, but it definitely extends to the office. And I think there are smart ways that you can be efficient in a patient-oriented way that also enhance profitability. So I collaborate with optometrists in my region extensively. I rarely see a patient that could see a good optometrist, and I make sure patients are in the care of good optometrists. I think that's harder in some regions than others. So it's hard to say that what I do, you could do in a larger center or even in a smaller center. But I do think thinking of ways to have patients seen elsewhere that you don't need to see, it allows you to see new referrals more. So today I did only new consults. I had no follow-ups. And I think you can do that if you have a practice that's constantly trying to not get rid of patients, but redirect patients. And I take that little extra effort to make sure they're seeing someone good. And I tell them, we work together, but if you need me, I'm here for you. But this doctor can take care of you in the meantime. And I think it's probably easier for me as a generalist than you as a glaucoma specialist to do that. But I think that is a way that you can make your practice a little more effective. There is this tipping point with being too fast, and then it impacts quality care. But it really varies between us. How many patients is that? I don't think you can come up with a number. And especially if you have trainees, if you have residents working with you, that can make you much more efficient or much less efficient, depending on the trainee. But also I have an optometrist, for example, that works for me and sees my post-ops. So I never see post-ops that are routine. Now, she sees them under my EMR. I'm medical legally in the care. She kind of works like a resident for me. But if there's an issue, I see them. But it allows me, again, to kind of really use my time optimally. And I think that's kind of the key to make sure that you're doing the things you want to do. But you also can't do everything. So when you're like the only glaucoma specialist in the community, like in our community, we only have one. I think it can really have a risk of burnout because the demands of you can be greater than what you can provide. So having a little balance in life, you have to spend time making sure you have it, because I think medicine will take everything you will give it. But I think we have to be efficient. Really, there's too few ophthalmologists, and there's only going to be fewer because of early retirements and residency numbers that took place right before these people right now that are about to retire. They were reduced. So we're going to have a shortage, and I think we have to work collaboratively and design smart, effective, efficient practices. The profitability thing that I worry about is not that. It's not what you were describing, where you're trying to get through all your patients so that you can see the ones that need to be seen. What I worry about with profitability that we're seeing in ophthalmology is kind of like a non-medical view of medicine. And we see it and we kind of accept it more commonly in veterinary medicine and dentistry, maybe even in optometry. I'm not really sure about optometry, but I have experienced it personally in dentistry and through veterinary medicine, where there's sort of this feeling like you can enhance all the non-insured services that you can find. You can enhance all of the insured services you can find. And as long as the patient's willing to pay or willing to have that service, that's okay. And I think that's where our system will fall apart if we take on that model. And we're seeing that a little bit in some profit-driven practices, where it's not really about what this patient needs. It's about what's going to bring us the biggest take home. But I would say that's hopefully the exception, but I'm worried about it being a trend.
Can you give an example are you suggesting things like patients are put on programs of routine monitoring that might not necessarily drive better care, where the monitoring for service, and then they're like on a sort of mill of high volumes, for example, of paid testing or something like that that's driving profits? Or what is it?
What the concerns I've seen raised, and it's actually a concern that is discussed, I would say, quite extensively amongst new ophthalmologists who are sort of facing this, because as a new ophthalmologist, our overheads are so high, it's kind of hard to just start from scratch. One of my colleagues did in residency, but I think he had to live in his parents' basement to be able to do it. Like most of us have to join as an associate for a few years, make a little money, and then, you can get a loan to be able to develop your own practice if you're going to have it.
I sat at an investment seminar almost I was well into a year into starting my own practice, even more, I think. And I was sitting at this seminar and I opened up my bank account for my colleague next to me. And I was like, I have $3 in my corporate bank account. And I'm about to lend myself money to pay my staff, because I had just decided, I was like, oh, I'm going to open my own shop. And then with each remittance, I would be buying the next piece of equipment and the next piece of equipment. And it was totally like just treading water for so long. It's a really hard thing to do. So the trainees,
it's a big upfront cost. Yeah.
And the cost of living across the board for our trainees is huge.
Yeah.
And the length of time that they spend trying to get into medical school is longer. And
so debts are higher. Yeah. So for sure, it's harder now than it was 40 years ago, for sure. And it's harder now than it was 10 years ago. So there's no question it's a concern for new grads. And I would say the pattern we're seeing is more like protocolized care. So, I value so much my independence, and I'm sure both of you do as well. If I see a patient and I think this patient needs this test, this procedure, whatever, I'm going to make it happen. And if I think it needs to be expedited, I'm going to expedite it. And if I think this needs to happen, I'm going to do it. And I really love that I have this autonomy as a surgeon to make these choices. And I would be very concerned to work in a setting where I felt like I didn't have control over what tests patients were told they had to have. And the protocolizing that we're seeing, and this is in I'm going to call it the mega practice. And I like to call it that because I think a group practice is awesome. I would love to work in a group if I didn't value more my time. I need to have flexibility so that if Wednesday, my kids have a concert, I thought it was Friday. So I have to move my Wednesday patients to Friday. And that only works because Friday is always available if I'm not in the office on Friday. So I need that kind of flexibility. But otherwise, there are so many great advantages to working in a group practice, the collegiality, you can share the expenses, you can share patients, get opinions. There's a lot of advantages. But the profit-driven mega practice is different. And this is where you say, okay, you are going to come into our practice. If you see a glaucoma patient, before they see you, these are the tests the glaucoma patient will be offered. Some of the tests are insured, some of them are non-insured. They will be discussed by an educator. But this educator is paid a commission based on whether a patient selects the test. The patient hasn't yet had a discussion with you, but the test is being ordered in your name. So you may feel powerless in this protocolized care pathway. The patient may be confronted with tests, sometimes up to, like for glaucoma, we've seen like $500 in testing before they see the surgeon. And essentially, you feel like you have no control over the pathway, but it's still being done in your name. So you are responsible for it. And I've seen so many different approaches. Some associates just feel like, well, that's the way it is. And they, what we were saying before, when you're kind of sheltered in residency programs, you may not feel like there is a different pathway. Like you may not be that experienced with how medicine works in the community. You may also feel like you have no choice because the ophthalmologists who run this practice may also be the ophthalmologists who assign privileges at the hospital. So, if you're smart, you're going to be an associate in the place where you want to work. And to get those privileges, you may have to be an associate. So I really, I have a lot of empathy for new grads trying to navigate this. And I think there's a lot of moral distress surrounding it.
It's totally fraught with conflict as well. I think we need to be these should be some difficult conversations, I think, with our colleagues. For those of us who are, again, as I said, as we kind of get more weathered in our careers, I think we can have these tougher discussions at meetings and say, let's talk about what this means for us as a whole.
But I do think it's important to recognize, like, why would it be there other than profit?
Right.
Because it's easy for me to say this is just profit-driven practices. And I do think there is a big profit component, but there's also some advantages to it. If you, Hattie, were to see a patient, the idea is like, you can only see so many patients. Yeah. You want to improve your throughput. If every patient you see has had all these tests done, every test you wish you could have in front of you on the computer, done at a separate visit, so that you can essentially make a very quick decision about care, give them their next steps. You don't have to see them again until their surgery or their procedure. I can see the advantages in it. So I can see why a protocolized approach like that has positives. But what I worry about is the barriers that it presents when patients can't pay for those tests. And then sometimes some of the non-insured tests or insured tests are actually not necessary for some patients. So there is this, it's sort of in the name of making it a faster, efficient system for the surgeon, you sort of sneak in some unnecessary testing that enhances profitability. So I think we can't always have efficiency trump everything, especially if it presents financial barriers to patients.
It's a lot. Thank you. As we kind of wrap up here, we've talked about so much. We like to do two things. It's really important to us that we get to talking just a little bit about you. So we're going to leave that for a moment. But before we do, tell me about what your hope is for the future of ethical standards. Do you think we should be regulating more? What would you love to see? If you could wave a magic wand and change something about the function of our system, what would it be? Would you employ a regulation? Would you enact a sunshine law where everything becomes public? What would you do?
I don't think I would do those things because I think they often are not as effective as you'd like. This is a magic wand, so it doesn't have to be something concrete. I would change attitudes. I think our biggest problem is an attitude one, where people kind of laugh about conflicts. They celebrate industry relationships only positively. So I really think if we could just change people's attitudes so that we value the discussions. And I would say that when you think ethics, people think, oh, boring. But when we talk ethics, it tends to be the stuff that actually we care about the most. So if we talked about it more at meetings, like Hattie was saying, like think about ways to incorporate it. I know at U of T, we had spoken once about having all U of T CME have a component of ethics for every meeting. Just, think like what could be a relevant topic for this meeting, whether it's glaucoma or retina or pediatrics, they exist in all of our spheres. It's not just this insured, non-insured stuff in cataracts. I think it just would give us more space to think about these issues that I know we all care about. We just don't always have time to think about.
Thank you. With respect to
Chryssa,
attitudes, I think you've shifted hours. So
yeah. Chryssa, I'm
Well,
just so happy that this podcast is only audio and not video because my facial expressions have just been through the roof. You've said so many things that have just made me think and it's been really amazing. So thank you for sharing so much with us. And I really feel like there needs to be like a clone of you in every province because we need to be talking about this more. And it's so pertinent to so many aspects of what we do on a daily basis, and also in terms of important trends that are happening in our country. And I really appreciate your input. So, as we read your bio, we think, you do nothing but ophthalmology related things because you feel it feels like you have your, a finger in many aspects of ophthalmology in Canada. But I know that you do many things outside of ophthalmology as well. So, one, can you like give us a percentage of what your time is quote unquote work related versus not work related, because I think that'll end up surprising us. And then if you can just share some of your favorite things outside of work, some of your personal interests and things you do outside of ophthalmology.
I work pretty full time, Hattie. Like my husband's an orthopedic surgeon, and I definitely have the busier practice of both of us. But I'm nothing like my sister, who's a general surgeon. So even when we work hard in ophthalmology, it's healthy to have perspective of other specialties. Like she's up all night. I'm on call right now and I haven't been paged. So I work 5 days a week, kind of 8:30 to 5, I guess. But our call schedule here is pretty awesome. So I only do 1 in 15 weekends. So that's pretty sweet. And I have 5 kids. That pretty much takes up all of my free time. And I have 3 dogs. So I'm officially kind of crazy. But I have such a full life. I feel so lucky. I live in Kitchener. Everything is so close. So, I can end my OR early, go home and make dinner, go back and see some post-ops, and then be home to have dinner with my kids at 5:30. The only way I could have 5 kids and work full time is that I have a lot of help. So, the kids have had the same nanny since my 15-year-old was born. And I just feel so fortunate to have so many great people in my life. My main hobby, I guess, outside of kids and ophthalmology is I do a lot of Bikram yoga. That's kind of my Zen. And I do a lot of music, but not really anything serious anymore.
Well, thank you so much on behalf of the EyeCan podcast. We're so grateful to have had you come on as a guest, and we look forward to future discussions. I look forward to comments from listeners. Please let us know your thoughts, and let us know what ideas, as you listen to this podcast, you have about more that you want to hear and more that you want to learn.
Well, thank you. It's been really a pleasure.
Thank you for joining us for this episode. We look forward to bringing you more engaging content over the coming months. EyeCan wants to know what you think. Please send your comments on today's episode or any suggestions you may have for topics or features to communications@cos-sco.ca, and we'll try to incorporate them into future episodes.
EyeCan veut savoir ce que vous en pensez. Veuillez envoyer vos commentaires sur le balado d'aujourd'hui ou vos recommandations de sujets à communication@cos-sco.ca et nous essaierons de les intégrer dans les prochains épisodes.
Season 5 of the EyeCan podcast is brought to you by Bayer Ophthalmology. We thank them for their support.
La saison 5 du balado EyeCan vous est offerte par Bayer. Nous les remercions pour leur soutien.
Thank you from the Canadian Ophthalmological Society. EyeCan is available wherever you listen to your podcasts, and of course, through the COS Practice Resource Center.
EyeCan est disponible partout où vous écoutez vos balados et bien sûr au Centre de ressources pour la pratique de la SCO.
EyeCan is written and directed by Kim Teitler and produced by John Allaire from Allaire Strategic Works.
EyeCan est écrit et réalisé par Kim Teitler et produit par John Allaire d'Allaire Strategic Works. Some episodes this season will include relevant links and show notes, so be sure to check episode descriptions to learn more. Certains épisodes de cette saison incluront des liens pertinents dans les notes d'émission, alors n'oubliez pas de consulter les descriptions des épisodes pour en savoir plus.
If any of our listeners have topic ideas to submit, please email them to communications@cos-sco.ca and we will review for consideration.